la mano.
Sí.
Yo le doy la palabra sin hacer clic en ninguna parte.
No, sí, sin hacer clic en ninguna parte. Usted, como es una reunión, el usuario tiene la posibilidad de prender y apagar su micrófono independientemente. Solo
Entonces,
usted sí diga el nombre de, digamos, Ángel vi que tiene una pregunta para saber a quién le está dando la palabra.
y pedirles que cuando terminen desconecten su teléfono.
Bajen la mano.
Digo, su micrófono y que bajen la mano. Ok.
Ajá, sí.
Ok. ¿Qué más?
Y solicitarle también a los asistentes que si no tienen alguna pregunta o algo así, mantengan el micrófono apagado para que la sesión pueda dirigirse correctamente, sin ninguna interrupción.
Ok. Lamentablemente no hay ninguna información sobre los ponentes. Nada más sus nombres. Yo los googleé, pero no tuve éxito, no encontré información sobre quiénes son. Entonces yo simplemente me limitaré a presentarlos como conocedores del sistema de salud de Dinamarca. ¿Así es?
Sí, de eso sí no tengo conocimiento,
Bueno,
discúlpeme.
bueno, eso haré. Y ellos tendrán entre los dos, según el programa, media hora para hacer su presentación, al parecer, de la 1:15 a la 1:45. Y a la 1:45 empezará el primer bloque de preguntas y respuestas.
Sí, correcto.
Muy bien. Pues yo creo que eso es todo, ¿no?
Sí, 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 es todo.
Bueno, entonces yo me vuelvo a conectar al 5 para la 1.
Correcto, doctor. Muchas gracias.
Muchas
Muchas
gracias a
gracias.
usted. Gracias, Yolixi.
¿Sabemos si el señor Michael Ostergreen es es uno de los ponentes?
Son dos, Michael Ostergren,
Sí, sí, yo
Kirsten.
estoy,
Ok,
estoy
Hello,
aquí, estoy aquí.
hello.
muy
Hola.
bien.
Doctor, para que sea más fácil para usted y pueda hablar en inglés, en la parte de abajo hay un icono que dice interpretación.
Ah, sí, 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 yo sé. Sí, sí,
Ok,
sin problemas.
muchas gracias.
De nada.
Ok. So,
Discúlpeme, doctor Michael Ostergreen, nada más para preguntarle si seleccionó el canal de inglés.
Ah, no sé, ¿dónde está el canal inglés?
At the bottom of your screen is
Ah,
the icon shape a globe. Click it and choose the
interpretation.
English
Ah, yeah,
channel.
yeah, 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 yeah. Perfect.
Thank you.
And I go and choose English, no?
Yes.
Perfect. Done. Yes, I hear you very well. Perfect. Yep. Yes, no, I have some AirPods. Yeah.
¿Escuchas lo que dicen?
Yeah,
Yeah,
I
¿esto lo
think
escuchas?
I'll just also test the video if it works.
¿Lo estoy
We'll
escuchando
just
yo?
see.
O sea,
Yeah, it works.
Ay, no, no están conectados.
Yeah, good.
Yoli, sí, tienes tu micrófono encendido.
Hello, Mrs. Kristen Wisborg. Can you hear me?
Hello, I can hear you. Nice to meet you.
Nice to meet you. Mrs. At the bottom of your screen is the icon shape a globe. Is the interpretation. Click it and choose the English channel, please.
Yeah. Can you please repeat what you just said?
Hi, Michael and Kirsten. This is Octavio. I will be moderating the session. So I didn't get any information, background information, your position. So I would ask you that at the beginning of your presentation, say a few things about what you do and what position you are in the Denmark health system. Is that okay?
Yeah,
That's fine.
I
Thank
think-
you.
Yeah, that's perfect.
Thank you. Thank you for being here.
Excuse me, Mrs. Kristen. You connect in tablet or in the phone, the smartphone?
It's a tablet. It's yeah, iPad.
Okay.
Is it not working?
In your tablet is the three dots. The push in
Yes.
the three dots.
Yeah.
And the interpretation. Select the interpretation.
Yeah, I have put on the English one.
Click it in English and
Yeah.
down.
Yes, I can hear you, Cecilia. Thank you.
Thank you.
That's fine. Thank you.
Thank you.
Alexa, timer en 20 minutos.
Ya. Muchas gracias, Eduardo, por todo el apoyo. Muy buenos días a todos y a todos. Gracias, Octavio. Muchas gracias por tu coordinación, Octavio. Muchas gracias.
Al contrario, gracias por la invitación.
Buen día, doctor.
Buenos días a todos. O buenas tardes.
Buenas tardes, Santiago. Buenas tardes.
¿Cómo estamos?
Buenas tardes, Víctor, caballero. Buenas tardes, Carolina. Fernando,
Saludos a todos. Buenas tardes.
Hay dos Santiagos.
Sí, sí.
Buenas tardes, doctor Ramírez Barba. Octavio, buenas tardes.
Hola, Fernando. Gusto verte.
Gusto es mío.
Hola, Héctor, buenas tardes.
Hola, muy buenas tardes. Jorge Armando, Mónica Vargas, buenas tardes. Rafael Gual, muy buenas tardes.
Buenas tardes.
Buenas tardes, bienvenido. Nos acompaña el doctor José Ángel Córdoba Villalobos. Muchas gracias, José Ángel, bienvenido.
José Ángel, qué gusto saludarte. Un abrazo.
Igualmente, muchos saludos.
Qué gusto verte, Mónica.
Sí, igualmente, muchos abrazos.
Igual. Saludos, Jorge. Armando. Víctor.
Saludos, gusto saludarte nuevamente y a todos los asistentes.
Puros amigos.
Sí, puros amigos, exactamente.
Bueno, reencontrarse después de muchas batallas juntos, ¿verdad?
Claro, claro, Víctor.
Estimado doctor José Ángel Córdoba, nuestro más querido reconocimiento y aprecio por siempre.
Gracias, Víctor. Igualmente.
Octavio Gómez, llevas mano y lo que tú decidas de aquí en adelante. Cierro el micrófono.
Ok. Creo que no va a haber necesidad de utilizar el inglés. Nos van a traducir. Entonces, si tengo algunas instrucciones para nuestros ponentes, ellos las escucharán en inglés. Eso es lo que tengo entendido. Entonces, pues a todos, muchísimas gracias por acudir a esta convocatoria, responder a esta convocatoria de este conversatorio. Construyamos una mejor salud, el caso de Dinamarca. Agradezco a Héctor Jaime, la organización y la invitación a este muy interesante evento. Tenemos dos ponentes que son grandes conocedores de un sistema de salud que de pronto se convirtió muy atractivo para para los mexicanos, ¿no? Es sin duda alguna el sistema de salud de Dinamarca uno de los mejores sistemas de salud del mundo. Es un sistema que le ofrece cobertura universal a sus ciudadanos. Dinamarca es un país que invierte una importante parte de su riqueza en la atención a la salud y ha podido montar un sistema de salud que ha generado resultados extraordinarios y altos niveles de satisfacción de los usuarios con los servicios recibidos. Pero ahora nos toca entrar en un poquitito de detalle y ver qué es lo que podemos aprender. Sin duda alguna, es uno de los modelos que no solo México, sino muchos países en vías de desarrollo tendrían que estudiar para aprender de él, y ese es básicamente el propósito de esta sesión. Permítame solamente describir de manera muy breve el programa. Vamos a tener a nuestros dos invitados, Michael Ostergren y Kirsten Bisberg, haciendo una presentación de media hora sobre el sistema de salud danés. Y después de esa media hora, vamos a tener 5 bloques de preguntas de 15 minutos. Yo creo que vamos a poder tomar en cada bloque entre 4 y 5 preguntas que yo sugiero se hagan de corrido y después les permitamos a nuestros invitados que respondan a ella. Yo concluiré cada uno de estos bloques y invitaré a una nueva ronda de preguntas en 5 ocasiones. Les pediría a todos nuestros invitados que mantengan su micrófono apagado durante la presentación, excepto cuando tomen la palabra. Como saben ustedes, van a poder tomar la palabra haciendo uso del botón de reacciones, donde van ustedes a poder levantar la mano. Yo me dirigiré a ustedes una vez que reconozca esta mano levantada. Podrán hacer su pregunta y les pediré que después bajen la mano y apaguen su micrófono para que podamos seguir con la sesión. Entonces, sin más, Héctor, si te parece, vamos a pedirle a nuestros invitados que tomen la palabra. Le pediría, si así les parece, que sea primero Kirsten Bisberg quien tome la palabra y después de más o menos 15 minutos sea Michael Ostergren el que complemente la presentación. Muchísimas gracias.
Hello, and thank you so much. Michael and I actually agreed that we have a shared presentation for you. So I think we will do the presentation together, and we have divided the slides between us. But I can just say a few words about myself before we start the presentation. I'm the Chief Medical Doctor at Copenhagen University Hospital, Bispebjerg and Frederiksberg. I've been in this position for 7 years, and before that I was in a similar position at Aarhus University Hospital. I was trained as a pediatrician, but went into leadership quite early in my career. Besides being a Chief Medical Director, I'm also a member of the Danish Medicine Council.
Thank you.
And thank you. Just very briefly, my name is Michael Ostergren. I'm a medical doctor with training in health services management, health economics from London School of Economics, also tropical medicine. I worked in the Danish health system for several years before I pursued an international career as a doctor for WHO with postings in Zambia, Uganda, the regional office for Europe, as well as for the headquarters in Geneva. And I'm still doing a lot of work for WHO in different capacities. Before we start, I think we would like to congratulate you that you are taking this initiative. We think this is a very important initiative to learn from other countries, not to replicate what other countries are doing, but perhaps finding different aspects that can be used in a different context. And I was just talking with Kirsten, maybe it's something we should do in Denmark as well, learning from other countries. I think we might learn from you and perhaps do a similar session in Denmark at some point. Let's see. We'll start the presentation and I'll share my screen. And let's see how it works. And everyone will just say, are you able to see the slide?
Yes.
Okay. Let me just see if I can get this little thing down.
Sí. Yes.
This. Okay. Yeah, we have put a few pictures from Denmark, from those of you who have been there. It's a very small country, as you can see, or not you can see, very surrounded by the sea. Denmark and is a very small country. I mean, our population is right now estimated 5.8 million only. It's a very little fraction of what you see in Mexico. And the share, and we'll come back to that, of the population over age of 65 is about 20%, but raising. We do have, this is the geography of Denmark, and within there we have 5 regions, which are important for the whole health system. We'll explain that later. And we have 98 municipalities. Just to get you an idea of the size and how the overall organization is. We have 3 administrative levels in health. We have the state that holds the overall regulatory, supervisory, and fiscal function. Then we have the regional level. We have 5. They are responsible for all health services, including hospitals, primary care, etc. They are led by regional councils that are politically elected within the region. And the regional work, including the health system, which is the major part of their work, is financed by a block grant from the state. About 75% of their budget is coming from the state. And the rest of their budget comes from the municipalities that is partly based on services provided. The municipalities are responsible for services more close to citizens. It is led by municipality councils, and these are also politically elected within each municipality. And finally, the municipalities and their activities are financed partly by grants from the state, but also by municipality taxes, which can be different from municipality to municipality. Kirsten, maybe the next one.
Yes, and I'll just go a bit deeper into what Michael just said, talking about these 3 levels that play a role into the Danish healthcare system. First of all, the state or the government, they have the, you can say, the overall responsibility for the healthcare system in Denmark. They make the national health policies, and they also set the overall framework for the budget for the healthcare system. And then we have what we call specialty planning, which is quite an important thing in Denmark. It's a plan that is made by what is here mentioned as SUM, that's actually the Danish health authorities, can decide on specialty functions, which hospital can actually provide this service to which patients. So it's not so that we have a look into later where we have hospitals in Denmark, but it's not so that all treatments can take place in every hospitals. And that was a very, very important thing years ago in Denmark, that we had to have fewer places where we had the treatment for the very special cases in Denmark. So what is in the last line in under the states is just some different authorities that we have in Denmark that take care of different aspects of healthcare. The first and maybe also the most important one is the Danish Health Authority. And this has, apart from also this specialty planning, it has actually a national responsibility for health issues and work to ensure that we have good public healthcare everywhere in the country. Then what is called here SST is dealing to ensure preparedness against infectious diseases and biological threats, as well as also controlling congenital diseases. So they of course played a very, very important role during COVID. Then what is said as SPAS, that is actually the Danish Patient Safety Authority, and they authorize all healthcare professionals, and they also supervise Danish healthcare professionals. And then the last one, LMS, that's a Danish medicines agency that authorizes and inspects pharmaceutical companies and also license medical products in the Danish market. So that is the state. And then we have the 5 regions, and their main task is hospital treatment, but they also make the contracting with the primary healthcare, and then they also have a function concerning adult dental care. But it's really the hospitals that take off most of most of the task in the regions. Then we have the municipalities, and it's important to know that yes, they take care of an important part of healthcare system, but they take care also of many other parts of what would be things to do in a municipality. That's roads, schools, etc. But here we are only focusing on the healthcare system. But what they take care of is nursing and acute function, prevention, and very importantly also rehabilitation. And they also take care of substance abuse treatment. And then they have the children's dental care in the municipalities. And we have in Denmark now 98 municipalities. So quite a lot of municipalities, but not as many as we had years ago. At that time, we had almost 300 back in 2007. The primary care service are delivered by self-employed general practitioners, and the regions make agreements about the payment with the general practitioners. They are the patient's first contact. You don't go to the hospital unless it's something acute. Then you go through the GPs, and then they can send you to the hospital if they see that is needed. But the GP is a very, very important part of the Danish healthcare system. And just to give you a number about this, that almost 95% of all the patients that GPs see are not sent to the hospital. So only just above 5% of the patients that the GPs see also have a visit at the hospitals. The hospitals are managed by the regions, as I said, and we have from the government goals that we have to meet, goals for waiting times, and of course also they decide about the financial resources. And if we at the hospitals, at the public hospitals, cannot meet these goals for waiting time for an appointment at the hospital, we are obliged to send the patient to the private sector. This is again a map of Denmark, but now you see we have put in the distribution of the hospitals around Denmark. The red dots, the emergency admissions, the orange, the trauma centers, and then we have also added the psychiatric emergency admissions. And just to give you a small feeling of the size of Denmark, from the very top called Skagen and to the south, that's the border to Germany, there's just around 400 kilometers. So it's very close distances these hospitals are situated in. And we have today much less hospitals than we had just years ago. Michael, du skal lige have lyd på.
So I believe that, I don't know if you would just go through the presentation. If you want questions at a certain point, please interrupt us. If you would like to stop and have some questions, or we just continue. Okay?
Creo que lo mejor va a ser que hagan su presentación completa y después entramos a las preguntas.
Perfect. So what we are doing is just to go through some of the main components and aspects of this health system. And obviously, the healthcare spending is very important. As you can see here, this is Denmark in the context of the European Union. And Denmark has a fairly high budget for health, which is mainly government and compulsory health insurance schemes. Actually, we are number 5 in Europe and among the 10 highest countries with the highest health budgets globally. What is important is also, and it reflects a little bit what Kirsten was saying, that the focus, of course, we have hospital care, but a lot of the focus is on primary care, and a lot of the work is actually done at the primary healthcare level by the general practitioner. And as you can see, that is also reflected in our healthcare spending. We are spending more on outpatient care than we are doing on inpatient care, which is on contrary to some other EU countries. What we can see here is that also within that spending, it's divided, as you could see, on outpatient care, inpatient care, long-term care, pharmaceuticals, prevention, administration, and others. And what we can see here, this is the pharmaceutical and medical devices. Actually, the proportion that Denmark is spending on pharmaceuticals and medical devices is accounting only for about 10% of the total health expenditure, which is different from a lot of the other European countries that are spending almost double as much. And this is because we have very strict cost containment measures for pharmaceuticals and medical devices. So even in a very robust, what can I say, in economical circumstances where the budget is very high, it is still important constantly to make priorities within that budget. And maybe Kirsten, you are sitting in the medical council that is advising on new treatments, which is not very easy sometimes. Maybe just a few words, Kirsten.
Yeah, the Danish Medicine Council, the role of it is to provide guidance about new medicines for use in the Danish hospital sector. So every month we meet, and the pharmaceutical companies, they can, when some new medicines comes up, they can ask the council if this can be used in a Danish context. And then they have to provide data about the, of course, which patients are going to be treated by this treatment, what are the side effects, but also about the cost with this medicine. and we then have to look into these data and to see if the benefits also are acceptable actually concerning the cost. So we can mostly we say no because we think, okay, this new medicine does not have the benefits that we are asking for. But we can also say, yeah, we can see that this new medicine can benefit some patient, but it's much too expensive. We can't spend that much money on that. So it's also prioritizing how to spend the money that we have for healthcare in Denmark.
And just to say, it's something that is in the media every now and then. There's a patient saying, I have this and this disease. I could maybe get a treatment for a big amount of money, but it has been denied to me. And these are very difficult to look at health for the most, and then how to spend on maybe one person if the treatment results are not that convincing.
But it is, can I just add, Michael, here that it's also so that even though the Danish Medicines Council had decided that this medicine cannot be used in that group of patients, the regions also have to have councils. In each region, we have council where doctors can ask us to look into, in this single patient, due to this and this reasons, can I use this medicine even though it is not allowed by the Danish Medical Council? So there's always a possibility that you can look into one single patient if there's something that makes this patient different from the reasons that the Danish Medical Council said no.
So just very roughly, our healthcare financing is to 80% is funded by government through general taxation. And the remaining 15% is the private spending. And out of the private spending, 13% is out-of-pocket payment. Typically, it is for partly paying for medicine, although there is a loss on how much an individual can spend in total on medicines, but there is a co-payment by patients if you get an antibiotics or other medicines. And only 2% of the healthcare financing is actually covered by voluntary health insurance, i.e. private health insurance. So it's very a public system. And this is just reflecting that the about 13%, which is the out-of-pocket payment by patients, you can see here that pharmaceuticals is one quarter of that. Dental care is another part, taking quite a lot of the out-of-pocket payment. If we look at coverage of health services, there are regular surveys within the EU looking at the proportion of the population in the EU, European Union countries, which surveys looking at health coverage. And here we are looking at unmet needs or unmet medical needs divided into the richest part of the population and the poorest part of the population. It's the other way around. This is the poorest part of the population. This is the richest. And you can see even for the poorest part of the population, unmet needs reported is below 4% of medical needs. If we look at dental needs, it looks a little bit different, and the spread is a bit higher because the public contributions to dental care is limited, meaning that particularly the poor part of the population have unmet needs for dental care. But still, I wouldn't say acceptable, but they are not very high, neither for dental care and for medical care. Interesting to see also, we talked about the primary health sector. Actually, 1/3 of all doctor consultations in Denmark are done through teleconsultations. And this is really the biggest part is the general practitioners, which are doing a major part of their consultations with patients on telephone or telemedicine. I know I heard from Kirsten that also in hospitals, you are also in the outpatients in the hospitals trying to use teleconsultations a little bit more than is being done right now. But Denmark is also within the EU elite, which partly also was the reason, partly why Denmark also came through the COVID pandemic fairly okay, because a lot of our contacts between the health system and patients are actually done by teleconsultation. Discussion, I mean, globally and worldwide, lack of health workforce is a major problem. And even in a country as Denmark, where we, compared to EU, we are quite on the higher side, both in terms of number of doctors and nurses per population. But still, there is a big discussion about shortages of health professionals. Right now, within the EU, you can cross the borders and work in other countries. There are quite a number also of doctors. About 10% of the Danish health workforce among the doctors do have their education and training from another country than in Denmark. So here we come to something interesting, because usually we would also like to see that a good system that where we have a good coverage, it's all financed very well, etc. We would of course also like to see that reflected in life expectancy, that we would have a higher life expectancy. And this is something that we are discussing a little bit in Denmark these days. How come that we have such a nice system, but if we look at the health status reflected in life expectancy, it's maybe not that good. At least there are many countries that are particularly better than us. And when we look at the Danish data, we can see that if we look at this is age standardized mortality among patients less than 75 years. That means that people dying prematurely, what do they die from? And then if you look at if they're dying from causes that are mainly dependent on a good hospital system, for example, prostate cancer, breast cancer, colon cancer, etc. Actually, we are doing fairly well, showing that the hospital system is pretty well functioning. While if we look at causes that mainly could be prevented, like lung cancer, which is usually coming if you have been smoking, or alcohol-related diseases, etc., there we are doing not as good as we are doing in the treatable. So some data could suggest that we in Denmark need to focus more on the prevention rather than the treatment part. Kirsten?
Yes, just to also look into some of the challenges that we are also facing in the Danish healthcare system. And here we're just showing you some numbers, and what they're showing is how many people or citizens in the you could say the working age 18 to 64 compared to people above 64 who among all are those also needing more health care. And back in 2000 it was factor 4.3, and when we get into 2040 it's a 0.2. So even though we have, as Michael just said, we have compared to other countries quite a lot of nurses and doctors, we are still facing the problem that especially we will see a lack of nurses, not only in the hospitals, but especially in the municipalities and the elderly care. They are really facing an increase in the number of people that need nursery and care from nurses. And this is also just to show you, it's actually telling a bit of the same story. It's to tell you how the percentage of citizen age 80 or above is increasing, and we have divided it into the 5 different regions. So also just to show you that there are some differences, and the lowest number of old people are in the what here's named as Region Hovedstaden. That means the central region of Denmark, where my hospital and Copenhagen is situated. So some regions are facing quite a bigger problem concerning this than others are. And again, this slide shows you also the proportion of citizens with chronic illness, and of course that also goes with the aging population. We also see more people having chronic illnesses, and that is also increasing in the years that we are looking into, and it will be increasing even further than what you can see on this picture. And again, the central region is the region with actually the lowest number. But what I always also say when I show this picture is that this is actually also part of the success of the Danish healthcare system, that people now survive their cancer, survive for longer with their chronic lung diseases and so forth. And this you will also have a view into in the next slide. And this is just
and Michael.
Yes.
Podemos tomar 5 minutos más para la presentación, para dar oportunidad a las preguntas. Estoy seguro que esta presentación va a generar muchos comentarios y preguntas.
Yes. We are
That's
just about
perfect.
to finish. We are just about
that's
to finish.
perfect. Yeah. So this is just showing you what I actually just say, that it's showing the number of people who are alive with a cancer increasing because we are having better treatment. People live longer with their cancer, but it also shows that we are much better on diagnosing cancers. We diagnose cancer at a much earlier stage, which also give a much lower mortality from the cancers. And then this shows you also some of the changes that we have seen in Denmark. We have a vast decrease in the number of beds in the hospital. The actual number on an overall scale is 2.5 hospital beds per every 1,000 citizens. And I can give you the number for my hospital. We serve a population of around 470,000 citizens, and we have around 1 bed per every 1,000 citizen in my catch-up area. And this is also just to show the changes in the last 20 or 40 years actually that we have seen in Denmark. Increase in discharges, increase in number of outpatient visits, decrease in hospital beds, and decrease in bed days at the hospitals, and then a vast decrease in number of organizational units. You can see this as hospital, but it's also because some hospitals, maybe 2 hospitals, have been made into one organizational unit, but much less hospitals than we had 20 and 40 years ago in Denmark. And then the average length of stays for our patients in the hospitals has also decreased quite a lot in the years that's passed. So it also means that the patients who are now in hospitals are quite sick, and still we can treat them in a very few days, most of the patients.
And this is our last slide. And this is really not to say good country, bad country, anything, but I thought that when we were discussing with the organizers here, it was understanding that, you know, try to see the Danish health system would be good. And then I looked at some of the OECD indicators, also when looking at Denmark in an international perspective. And I've just, you know, looked a little bit on risk factors for health in Denmark and Mexico. And this is not a comparison, 2 different countries. They have very different backgrounds, but still looking at some of the risk factors where actually it looks like Mexico on some of the risk factors are doing better than we are. This is what we are also struggling with, alcohol and smoking. Obesity looks a little more frequent in Mexico, but there is also a difference in self-reported and measured. Normally, the measured are higher than self-reported. Access to care. Here, the 100% more or less in OECD. Mexico about 74, 72%, as it was reported. Actually, satisfaction is pretty good. It's almost OECD average in Mexico. So it's apparently patient satisfaction is relatively good. It's very good in Denmark, but also relatively good in Mexico. And then expenditure covered by compulsory schemes. Percentage in Denmark, it's 85%. In Mexico, it's reported with OECD. You may have other data, but about 5%. I think I will just leave this. I thought it could be interesting just to look at some key indicators also when we are having discussion where is Mexico also doing much better, where there's still a long gap to reach. But I think in interest of time, I think we can stop our presentation. Should I stop the presentation, and then if there are questions, we can go back and we can share again, no? Okay.
Muy bien, muchísimas gracias. Es una presentación muy rica, muy clara y creo que muy interesante. Creo que hay muchos datos que indican por qué México ha estado tan interesado en conocer el sistema de salud danés, ¿no? Es un sistema muy bien financiado, con una población que está envejeciendo de manera acelerada, lo que representa un reto enorme, pero están dedicando una cantidad considerable de recursos a la atención de la salud. Muy interesante constatar que hay esta clarísima transición hacia la atención de primer nivel y la atención comunitaria, y que están dejando atrás el modelo hospitalario. Llama mucho la atención la cantidad de enfermeras que tienen per cápita en Dinamarca. Héctor Jaime, creo que sería muy útil que pudiéramos, si es posible, contar con la presentación para distribuirla eventualmente, porque tiene información muy, muy rica. Empecemos entonces con las preguntas. Armando tiene la mano levantada. Repito las instrucciones. Una vez que terminen, bajen la mano y apaguen su micrófono. Adelante, Armando.
Buenas tardes aquí en México, buenas noches allá en Dinamarca. Agradezco al doctor Héctor Jaime, Octavio, Fernando, la coordinación, a los doctores Michael y Kristen, su brillante exposición. Nosotros en México, pues la atención primaria de salud la consideramos también sobresaliente, pero en un 85% es donde descansa en este momento aproximadamente esa atención. Y obviamente también tenemos que mejorar la promoción. Primera pregunta, pues se supone que hay una capacitación permanente, todo este primer grupo de colaboradores de la atención primaria de la salud, y nosotros al menos el 30% antes de este gobierno se dedicaban a la atención primaria a la salud, a la prevención de enfermedades. Otro punto, bueno, pues Dinamarca, perdón.
Tratemos de limitar nuestras preguntas para dar...
Perfecto, ok. Bueno, mira, Dinamarca es uno de los países más felices del mundo en los últimos años en el ranking mundial. Y más sin embargo, yo cuando estuve el año pasado allá en Dinamarca les decía cuál es el motivo, por qué son tan felices, y hablaban también del alcohol y hablaban también de que tomaban muchos antidepresivos. Entonces, ¿qué están haciendo para ir revirtiendo? Incluso también los suicidios, sé que están mejorando, pero la salud mental creo que es trascendente en todo el mundo. ¿Qué están haciendo para revertir esos altos índices de alcoholismo, de el uso de antidepresivos, de ansiolíticos, y para reducir los suicidios? Es mi comentario, y bueno, pues hay que seguir disfrutando el higi danés.
Muchas gracias, Armando. Vamos a tomar la siguiente. Vamos a tomar 2 o 3 preguntas y después les daremos la oportunidad a Michael y Kirsten que nos respondan. Adelante, Fernando.
Gracias, buenas tardes. Bueno, sin duda, el sistema de salud danés es predominantemente público, solamente el 15% del gasto en salud es gasto privado. Muy concreta mi pregunta, ¿qué porcentaje de la población se deriva de la población que acude a el sector público y que no puede ser atendido por diferentes causas, entre ellas por los largos tiempos de espera? ¿Qué porcentaje de la población se deriva al sector privado? Gracias.
Muy bien. Tomemos una tercera, Santiago.
Muchas gracias. Mi pregunta es muy concreta. Independientemente del financiamiento, es decir, el pago, el financiamiento que tiene el sistema de salud en Dinamarca, 85% público y 15% privado, a mí me gustaría distinguir qué porcentaje de los servicios otorgados son otorgados a través del sector privado. Es decir, qué rol o papel formal juega el sector privado en la producción y prestación de servicios, porque nos damos cuenta que la atención primaria de la salud es subcontratada mayoritariamente.
Gracias. Tomemos también una última. Santos Regino, adelante.
Muchas gracias. Gracias por compartir esta importante información. En nuestro país, México, los establecimientos de salud tienen importantes áreas de oportunidad en sus condiciones de operación, y nuestro sistema de salud, las instituciones tienen bajo desempeño en cuanto a su capacidad para detectar la enfermedad en etapa temprana, iniciar oportunamente el tratamiento y proporcionar el tratamiento adecuado en tiempo y forma. Mis preguntas son 2. ¿Con qué periodicidad y qué metodología utilizan para gestionar las condiciones de operación de la infraestructura y el desempeño del proceso de atención médica? Y la segunda pregunta es, ¿cuál es la profundidad o el tipo de participación social en los eventos de evaluación y en la toma de decisiones para mejorar esos indicadores? Gracias por la oportunidad.
Bueno, adelante, Miquel y Kirsten.
Okay, I can try to start on answering some of the questions, and then you can join, Michael. Maybe I should start with some of the last questions. This about, and I understand, and it's also actually quite difficult to explain this about how much is taking place in the public and how much is taking place in the private sector. First of all, almost all of the healthcare system in Denmark is actually public. We said, and it's also said on the slide, that the GPs are private. It might not be the right word to actually say that they are private, because yes, they have their own economy, but all the money that they own come from the regions. And they make agreements, not single. All the private, all the GPs have an agreement with the regions. You have so many patients that you see. So for that you get this amount of money, and then each time you see a patient, you also get a specific amount of money. But it's also that they cannot earn more than a specific amount of money per year, which is always also made in an agreement between the region and the GPs. So that's also how you try to, say how much money can we spend on what is taking place in primary care concerning the GPs. Then we also showed you that in the hospitals we have what we call patient rights. That if we cannot see the patient within a month, if we cannot offer surgery within a month, if needed, we are obliged to offer the patient to go to the private sector, and that is paid in our region by the hospital. With the money that we get from the region to run the hospital. But it is actually the private sector concerning that kind of care is very small in Denmark. It's like, I think at the moment 1.5% of the budget that goes out to the private sector, and it's been rising in the last year. That's only because of COVID. Where we had to close down the hospitals for a period, and due to that we got some waiting time in our hospitals, and we are working hard so that we can offer patients treatment within the time limits that the government tell us that we have to live up to. So that was, I hope, answer to one of the questions at least.
Sí.
Yeah, there was a little bit. There was a little bit about the alcohol and antidepressants. I don't think. I mean, suicide rates, as far as I remember, are not that high on neither global or European level. So our suicide rates are not that high. The number of people on antidepressants is probably a sum of people who are depressed, but also whether you have a system that will catch and treat patients with antidepressives. So it gives both. In terms of alcohol, we have had, particularly among younger generations, we have had a very high intake of alcohol compared to also other European countries. It is something that has been done, a lot of health promotion campaigns, etc. And the newest data I have seen actually shows that the consumption is going down, just as we have seen also with smoking that was extremely high just 15 years ago. That has decreased quite a lot in Denmark. But it is a matter of also health promotion and probably a lot of factors that is beyond the health system. I think it's something we haven't, and yeah, I think we covered this about the private hospitals, and which is playing a minor role in the Danish health system. Yeah.
La evaluación, la participación de los ciudadanos en la evaluación del desempeño del sistema.
Yeah, okay, Kirsten, yeah, please.
Yeah, I mean, we actually ask the patients regularly when they have visited the hospitals. That's done both on a regional level and also on a national level. And we're just receiving the latest data on this from the national review on this, where the patients are asked to rate their visit at the hospital, and they ask, were they involved in their treatment? Did they understand the information that they had? Were they overall satisfied with the treatment that they had? And quite a lot of other questions. And then we look into this, and we can look into it at the regional level, at the hospital level, but also into each department. We look into this, and we look at inpatient patients and out clinic patients and acute patients, and so they go very much in detail, these status, and it's something that we take very, very serious and work with every time we have these data. So, and then also at the hospital levels, we from time to time also have our own reviews from the patients. Yes.
And maybe just to add, the fact that those who are basically running the hospitals in the regions, they are on election every 4 years. So it is also, I mean, they are being tested also politically. So the engagement and in Denmark, the health system, if something goes wrong, it is a major political issue all the time in Denmark, whether our health system works. That's for many people also feeling an indicator of this. We need to have a system, a welfare system that live up to the expectations. So that direct, every 4 years, there's elections for these regional councils and the municipalities.
Muchas gracias. Entonces, pasemos a otra ronda de preguntas. Vamos primero con Elena Castro y después con Jorge Sánchez. Elena.
Sí, muy amable, muchas gracias. Yo agradecer al doctor Héctor Jaime la invitación y me interesa mucho saber la prevención. Primero felicitarlo, doctor Michael, porque la prevención creo que es la diferencia, el diagnóstico temprano y la prevención. ¿Qué se hace en términos de salud psiquiátrica, de psiquiatría, salud mental, en la intervención en menores para evitar que se desarrollen las comorbilidades y así reducir el nivel de pacientes psiquiátricos en Dinamarca? Muchas gracias.
Jorge. Jorge Sánchez. Adelante.
¿Tienes tu micrófono, Jorge Manuel?
Maricruz Ríos.
Bueno, podemos pasar a responder esta pregunta mientras...
Creo que ya volví, ya me están escuchando.
Ok.
Sí. Bueno, agradecer la invitación y la excelente presentación, muy concreto, dado los datos, cómo los controlan. Quisiera preguntar, ¿cuál es el promedio de días de incapacidad por enfermedad en la población productiva? Y si tienen estos datos asociados a su impacto en el Producto Interno Bruto. Muchas gracias.
Adelante, Michael, Kristen.
Yes, let me try first on the first question, how we try to prevent mental health sickness as I understand it. I can just add to the answer for previous answer that we are in Denmark now concerned about mental health problems in children and young people, which have accelerated also during COVID. It was seen or rising before COVID, but it's certainly rising during COVID. And there's a lot of focus on how to support these young children. We think that it's not as much the healthcare system that should actually play a role, but as much the schools and the surroundings around the kids. How we actually prevent mental health illnesses. I think that actually, again, we have to point to the GPs that take care of a lot of also mental health illnesses. It's maybe not prevention, but it might be that it doesn't go that. I mean, they don't get that ill before actually a doctor takes care of it. So they might not need the specialized treatment in a psychiatric department. But I think we have not. I don't know, Michael, but I can't really think of what else would we do to prevent mental health. Besides, I think what is done generally in the society to have a safe and society and schools available for everybody, and we have a very low unemployment at the moment. So I think maybe these things are more important here than what actually the healthcare system does in this case.
But I think about the mental health, it is an issue that is still a problem in the Danish health system. I think we are better to deal with colon cancers and breast cancers and prostate cancers than we are doing with mental health. And right now we also see, particularly also for younger people, that the number of youth psychiatrists are not that many. So the waiting times where we have, and Kirsten, you may say if I'm right, we have right now for cancers, we have almost no waiting time. It's a whole schedule that if there's any little sign of a cancer, you have a kind of a highway you go through, and it goes very, very fast. With mental illnesses, I think we are still lacking somewhat behind, and that's a challenge right now. Would you agree, Kirsten?
Yeah, I very much agree that we really have a lack here. But what we also have a lack is that those suffering from psychiatric diseases, they are also underdiagnosed concerning and undertreated concerning their somatic illnesses. So we see a huge difference in the mean age at death compared to the background population. So we have a big issue here. In Denmark, it's so that you have somatic hospitals and then you have psychiatric hospitals, and they are led by different directions. So in my hospitals, we do not take care of psychiatric patients. We take only care of patients with some somatic diseases. And that might be one of the problems that these patients are undertreated, also for their somatic illnesses. Yes.
Muy bien, tomemos 3 preguntas más. Jorge, John, Héctor Jaime y después Carolina. Adelante.
Muchísimas gracias. La pregunta es, ¿cómo se asegura la calidad de los médicos y de la atención médica en Dinamarca? ¿Hay evaluaciones por parte del gobierno? ¿Cómo se hace? Gracias.
Mi pregunta tiene que ver con 2 temas. El primero, dada la cantidad de teleconsultas que ustedes realizan, hay un expediente único electrónico en todo el sistema y no importa vaya de atención primaria a un sistema de un hospital subespecializado, regresa y la base del expediente está en la atención primaria de la salud. Y la segunda es, ¿cómo validan la calidad de la atención médica de teleconsulta? Para saber, pues, minimizar un poco los posibles errores que pudiera haber. Esa es la primera pregunta. Y la segunda, que me parece relevante, es cada cuánto se revisan los tiempos de espera que pone el Estado. Yo entiendo que si el problema es agudo por una apendicitis, pues se resuelve de inmediato, digamos 24, 48 horas. Pero si se trata de hacer un reemplazo de cadera, quizás se vaya 6 meses. Hay estándares que los pone el gobierno, se hacen en conjunto para definir este tipo de enlaces. ¿Es cuánto?
Carolina.
Hola, buenas tardes. Mi pregunta tiene que ver con la coordinación que se hace entre los municipios, las regiones y el Estado. ¿Cómo es que fluye tanto el dinero, que es muy importante, pero sobre todo cómo se refiere a los pacientes de la atención primaria a el siguiente nivel de atención? Gracias.
Tomemos una última, Cecilia.
Muchas gracias. Buenas tardes. Buenas noches. Mi pregunta es con relación a lo que ustedes mencionaron de que muchas terapias no son aplicadas en el sistema público porque no son, digamos, costo efectivas. Entonces, ¿qué pasa cuando un paciente exige que se le aplique determinada terapia? ¿Cómo lo convencen o cuáles son los pasos para que el sistema no se vea demandado por un lado por los proveedores de esas terapias o también por los pacientes? Muchas gracias.
Ok, de nuevo con ustedes, Kirsten y Michael.
I don't know. I'm very, very good questions. I could maybe address a few and then Kirsten, particularly on also the treatment not available. I think you're the one who is working on that very hands-on currently. In terms of money flow, the flow is block grants that the government allocates to the regions. And then there is a negotiation. So basically, sometimes there can also be a problem at the political level that the regions get a block grant, and then the government says you have to do A, B, C, D, treat so and so many patients with these and these waiting times. And then the regions comes back and say, we do not have enough resources if we're going to meet these and these waiting times. So that's kind of a political struggle, but otherwise the block grant, the size of it, are politically determined and through negotiations between the state, the regions, and the municipalities. The teleconsultations, yes, we have electronic patient journal. So each citizen, if I have been to a hospital or to my doctor, I can go in and read exactly the same thing as my doctor can read. So even all the citizens will, through the web, be able to read your own file. So sometimes it's not advisable if you are not a doctor yourself to do it, but this is the thing. So that is a file that circulates and is with the patient, and the patient, him or herself, can also look in the file. The quality standards, I don't know, Kirsten, maybe you will take on that. And
yeah, I can add some of that, and I just also want to comment on this because you said you asked so many important questions, but just let me add on this with the single electronic system that I heard was asked about. And we do not, unfortunately, in Denmark have one single electronic system. Even in the hospitals, we have this different system in the different regions. And also the GPs have another system and the municipalities have another system. And that gives problems when we are working together across from the municipality to the hospital and to the GPs. We can send information to the municipality. We can send information to the GPs, but we do not work on the same system. And as a patient, you can see all the files from the hospital, but you cannot see the files from the GPs. That's one of the things that I hope very much will be possible in the future. But we're working on it, and the thing that Michael is talking about is very, very important, that the patients can see their own data from the hospital. About quality, and I think you also asked about how we can be sure that I'm talking now about our doctors, that they are well educated. It's so that in Denmark, after you finish or after you graduate from university, you have to go through a very formal education or training while working as a doctor. And this takes to get a specialty degree, and it takes 5, 6, sometimes 7 years before you can claim that you're a specialist in pediatrics or whatever. And in each specialty, you have to go through a certain number of things that you need to learn for each year that you go through this training. And that's one way to secure that every doctor has skills that we are asking for. We do not make examination. It's been discussed just previously again, and we decided not to have examination. We do not think that that's the right way to ensure that the doctors have the right competencies. About quality on an overall scale, that's also very, very important for us. It's important for of course, for the patients. It's also something that the government look into. We have national databases within a lot of specialties that we need to report data into, and then we can look into how are we performing according to the standards? Are we below national level, and so forth? And then we also work with it in our own hospital, continuously working on providing the patients with the quality that we want to deliver to our patients. So it takes up a lot of time, and to ensure that we always have a high quality level. And also what I said about the Danish Medical Council, that is also a thing that they have a high focus on, also to ensure that the quality of healthcare is the same or have a high level, whether you are in Copenhagen or you are in a smaller hospital in other part of the country. Then,
oh no, just continue. It was just to question I wanted to make a remark.
Yeah, there was also a question about the waiting time. How often we review this, and I must say, we always have focus on our waiting time, and I know exactly how many patients are on our waiting list for surgery at the moment, because that's where we have our waiting time at the moment. So we know the exact number of patients, we know the exact number of months they are waiting, we know the exact number of patients that we each month offer treatment in the private sector. So that is for us very, very important. And also the region looks into these data for each hospital, and we have also to report on a national level on this. So this have a really, it's really a main focus for us. It's politically decided, these waiting times. It's not something that we were asked about, and has also been some criticism of these waiting time, because it's concerning almost every illnesses. And of course, something is more important to treat very quickly than others are. Michael's just said that if you suspect cancer, you will get, no way you get into the system and everything goes very, very fast. We have packages for each cancer and very, very clear time limits for how long time things can take. But even if you have need a knee operation, maybe you need a new knee, this also needs to be done very fast, and sometimes that might not even be the best treatment of the patients in my view. But we have to live up to these time limits for every patient.
Yeah, just to say that I looked recently at some data, EU data, and our waiting times for bulk operations like hip replacement, knee replacement, and cataract operations are among the shortest in the EU, actually. So the waiting times in general are not that long, and for cancers, as we have said many times, they're extremely short. It's about days if you are suspecting a cancer before you for the investigations. Yeah.
I'm very sorry if I just wanted to say, I have a few comments. I'm very sorry that if I gave the impressions that many treatments are not available in the public hospitals, because that's not the case. Most treatments are available. It's only the very, very expensive treatment with maybe very, very limited effect that are not offered by the hospitals. We actually, I mean, it's not so that there are many treatments that you can't get in a public hospital, not at all. It's very, very few treatment, and it's actually a few new medicines that the Danish Medicines Council say no to. Mostly they say yes, actually, even though it's very, very expensive, and even though it has only, I mean, limited effect on survival in the patients. Then there was also a last question on the coordination with the municipalities or coordination between municipalities and the regions. And that is, I mean, what we are looking very much into at the moment. And there's no doubt about that the government wants much more healthcare in the primary sector and much less to be done in the hospitals. And they want this coordination between the hospitals and the municipalities to be much better than what it is today. I think we are working hard on this. How can we coordinate? How can we make much better treatment from for the whole for all the patients' needs, not only looking for my part at what takes place in the hospitals, but to look on the whole length of illness period for a given patient. So that is something that we are struggling with and working with, and I think it's a very, very important issue in Denmark. And we said also in the beginning that we should also look in other countries, and Denmark have actually looked to Finland to see how have they structured their health care system, and we are quite inspired also by the changes that they just recently made in Finland. Thank you.
Tienes cerrado tu micrófono, Octavio. Tienes cerrado tu micrófono.
Hay en el chat dos preguntas que yo quisiera hacer. Una, Dinamarca tiene muy buenos resultados en condiciones de salud, tiene muy buenos indicadores en condiciones de salud y tiene altos niveles de satisfacción de su población con el sistema. ¿Cuáles serían ustedes las cosas que destacarían como aciertos del sistema de salud danés? Casi como recomendaciones para otros sistemas de salud de otras partes del mundo. La otra pregunta también del chat es, ¿han tenido problemas de quejas en el manejo confidencial de la información con este amplio acceso a los expedientes clínicos. Y pasamos con Santos y después con Héctor Jaime de nuevo, creo. Adelante, Santos.
Sí, gracias. Dinamarca es parte del Pacto de Gobierno Abierto y me gustaría saber cuál es la profundidad de la participación social en la toma de decisiones e insistir en que, en el sentido en que el doctor Octavio nos menciona, que nos compartan la metodología de gestión del sistema de salud con base en indicadores de eficacia, eficiencia y efectividad. Gracias.
Héctor, ¿tenías una pregunta?
Sí, dos preguntas adicionales a Kirsten y a Michael. ¿Qué porcentaje de los casos son litigados en cortes europeas de derechos humanos por no tener buen resultado médico? ¿Y qué porcentaje de los casos son judicializados y que ustedes tengan que atender cuando alguien, porque sea muy caro el tratamiento, no es atendido y que recurra al Poder Judicial para su tema? Uno, en la propia, o el propio organismo de derechos humanos de su estado, sin cuántos se resuelven en Estrasburgo, si es el caso.
Kirsten, Michael.
I think we don't have cases that go to Strasbourg and actually also not to the Danish court system. It is so that in Denmark, if something goes wrong in the hospital and things go by time to time wrong also in the Danish hospitals, then we have a system where the patients can get some money if it is looked upon that the hospital or the doctors working there has not living up to what would be high specialist standard. So that is how it is working. Yeah,
it's an insurance system for all patients. They don't have to have that insurance themselves. They are just covered whenever.
So and we I mean patients don't sue us due to treatment that they did not receive. But as Michael said, there's quite a lot of writing about it in the papers from time to time. But I think also there is in the Danish population an understanding that also even in Denmark we have limited resources that we can spend on healthcare, and we apply to secure that we get the most health out of the money that we spend on the healthcare system. And I think there was this. I understood a question that how do we work with efficiency in the hospitals, as I understood it, and we always look into how can we provide actually the best treatment to our patients within the finance that we get from the region. We are constantly looking into how can we change this or that so that we can with the finance that are available for us, how could we offer the patients the best treatment? Even just a few years ago, it was so that in the hospitals, if you gave more treatment, if you we had a system where every treatment that we provided in the hospital also was followed by some money. But that's not the way we do it today. Today we talk much more about that this population we have to take care of. We have to provide the best health care with the finance that we are given. And I think that's a much better system. But we are constantly trying to improve what we are providing and always have a focus on that.
And then there was a question about what could be the successes, and
Mm.
And of course, this is a very subjective question. What do you regard? But I think for myself, having done assessment and analysis of health systems in numerous countries around the world, and then also looking at my own country, I think actually some very important factors is the very strong primary healthcare system that we have talked about, the general practitioners as gatekeepers, but also taking the biggest proportion of all patient contacts happens at the primary level, and you cannot bypass it. The other one is, of course, that the system, this is tax-based, but other countries in, for example, Germany has a compulsory health insurance linked to the workplaces. But in Denmark, we have a tax-based system. And I think that gives, of course, there will always be inequalities, but in terms of health, I think whether you're rich or poor, or whether you are whoever you are, you will get the same treatment in the system in Denmark. And I think that, together with a high coverage of essential services, is the most important things in the Danish health system, I would say. I don't know, Kirsten, if you agree.
I very much agree on this, Michael. That was also what I had written down. And I would just add one thing, and that's what we have also talked about earlier, this centralization that had actually taken part in Denmark, and the specialty plans that comes from the Danish Health Authority. I also think that's important, because that's also a way to secure the quality of the treatment that we offer our patients, that not every treatment should take place in every hospital, depending on the number of patients that need these treatment. Because we think that, for example, a specialized treatment, you really need to do it again and again and again to really have the highest quality on this treatment, so that what is not common need to be offered only in few hospitals. Most of the treatments that we offer patients, 90%, is something that takes place in every hospital, but the last 10% is only in a few hospitals, depending on the number of patients, and that it's a central authorities that can make these decisions, not the single hospital.
Hay una pregunta relacionada con el nivel de cobertura de tratamientos costosos. Es alto el porcentaje de intervenciones costosas que están cubiertas, por ejemplo, los trasplantes.
Yes, if a patient needs an organ transplantation, it only takes place in the public hospitals, and that is covered by the tax-based that finance the hospitals. So you don't pay that treatment yourself. So there's actually in the hospitals and at the GPs, there are no in Denmark, no treatments that you need to pay yourself as a patient. It's all paid by general taxes.
¿Alguna pregunta adicional?
If you have serious illness, the only safe place to be treated is the public system. The private hospitals in Denmark cannot, give very advanced services. They can do some standard operations, like a knee, hip replacements, etc. But as soon as we are talking about organ transplantations, complicated cases, it's all in the public system. And even if you are a multi-billionaire in Denmark, you would still go to the public system and not go to any private hospitals for serious illnesses.
Yo tengo una pregunta. Son sorprendentes los altos niveles de satisfacción. Michael hablaba de niveles de satisfacción por arriba del 80%. Lo mismo sucede con los trabajadores de la salud. Los trabajadores del sistema de salud danés están satisfechos con su sistema, se muestran igual de satisfechos que los ciudadanos y que los pacientes.
I think that's also a very good question. And in our region, we are asking all our workers every 6 months, both if they are satisfied about their working conditions, and then also we ask them, would you recommend your department, your hospital, if somebody got ill? And that's, for me, that might be the most important question, because if we cannot recommend our own hospital to our family, to our friends, I think we really have a problem. And I'm happy to say that we have both a high satisfaction about our employees and also a high rating of our hospital among our employees. And I'm sure, I don't know the detail of these data from other hospitals, but I'm sure they are quite the same in other hospitals in Denmark.
And just to say that, I mean, another way to look at it would also be, to which extent can you retain health workers in the system? And right now, there's just the contractual arrangements between the state and the government and the regions and the nurses association, etc., have just been finalized, giving some more pay raise for nurses, which has been a problem for some time, because nurses have, I mean, in Denmark, there's no unemployment. So you can get employed everywhere, and there's need of hands everywhere in all sectors. And that means that we have seen that particularly some nurses, but also other people in the health sector have maybe gone away from those departments with a lot of night calls, weekend calls, simply because it's difficult to combine that with a family life. And the government has then tried to compensate, so salary-wise, to increase the kind of the bonuses for working on in nights and weekends and so on. So this is a constant. It's another way to look at, are you satisfied with your own work and your own working conditions? But in general, I think most health workers are. I don't know if you have something to that, Kirsten.
No, that's true. I mean, also we have had especially problems with having enough nurses, and especially in these departments where there are a lot of night shifts. And we hope very much that this agreement that was just made will help us in that case. But even though, I mean, even we have seen that some of our nurses have left their hospitals and their work as nurses, we at the same time see a high satisfaction level among our nurses. I mean, I'm worried because we won't have the workforce that we have been used to, and we have an increasing number of elderly and people with chronic illnesses, and that balance will for sure force us to think differently how we provide services and healthcare to our patients and our elderly citizens. We cannot have the same number of nurses that we have been used to. So we have to rethink how we provide healthcare in the future. That's for sure. And in that case, we are looking into Japan, who has already vast problems due to an elderly population.
Aquí Lucelvia Vera nos pregunta sobre el asunto del sobrepeso y la obesidad. Dice ella que Dinamarca tiene una de las prevalencias de sobrepeso y obesidad más bajas de la Unión Europea. ¿Hay algo que lo explique en particular? ¿Ha habido estrategias que hayan resultado particularmente exitosas?
Overweight and obesity is still on the increase in Denmark as well. So we have not found the magic thing to do to avoid it. But it is true that if we look at the EU, I've seen for youth, actually that the Southern European countries are kind of leading a little more than the Northern and the Scandinavian countries, or leading, but having higher rates of overweight and obesity. In Denmark, we showed some of the pictures in our presentation when we started. I mean, still bicycling is something which is normal to do. I'm sure even Kirsten, when I go to work and so on, I always do it on a bicycle, even if I do have a car, but if you are going around in Copenhagen, you do it on a bicycle. So there is, I think, physical activity is somewhat higher in Denmark among younger people. I've only looked at young people than you see in other parts of Europe. But otherwise, I think it's a pandemic that hits particularly the poor part of the population, it's also a social issue. There's been a lot of debate. I mean, but that is not from the health system. You can do a lot of health promotion, but still, if you go to the supermarket and the cheapest is to buy processed food, then many will do it. So there's a lot of other aspects and also political discussions in Denmark around that. Should you put a special tax on processed food or put less VAT on vegetables, etc. So these are some instruments you can use. But we have not done that to a big degree in Denmark yet. There are discussions about it.
I fully agree on that, and that also there was a question also earlier on prevention, and how much do we do about prevention in the Danish healthcare system? And in my opinion, we do much too less, and that goes with overweight, that goes with alcohol abuse, that goes with tobacco. So I think we really need to focus much more on this, and I'm quite concerned about the increasing obesity in the Danish population, especially among children. So I think we need to focus much more on this.
Bueno, no sé qué piensas, Héctor. Me parece que tuvimos una presentación espléndida, muy buenas preguntas. Creo que la presentación satisface muchísima de la curiosidad que teníamos muchos mexicanos respecto de cómo operaba el sistema danés. No sé si nuestros invitados lo sepan, pero ha habido durante esta administración federal mucha discusión alrededor de construir nuestro sistema de salud utilizando como modelo el sistema de salud danés. Yo siempre he dicho que es uno de los, sin duda, uno de los mejores sistemas en el mundo y que no había sido una mala idea ponerlos a ustedes como ejemplo, como lo mostró la sesión de hoy. Creo que la información fue muy útil, muy clara, y yo dejaría en manos de Héctor un comentario final.
Primero, muchas gracias, Kristen, muchas gracias, Michael, por este apoyo. Quiero agradecer también en esta mesa al doctor Carlos Santos Burgoa, que nos ayudó. Gracias a la amistad con ustedes pudimos lograrlo. Agradecer también, sin duda, al doctor Jesús Felipe González Roldán, quien coordina estos seminarios de manera global. También muchas gracias. Y a todos ustedes, creo que pudimos contrastar hoy lo que se decía, que a dónde iba el sistema danés mexicano y en dónde está el de ustedes. También reconocer que nuestro país es un país de casi 2 millones de kilómetros cuadrados, 130 millones de habitantes, algunos más que los que tienen ustedes, pero los retos y las buenas prácticas, sin duda que nos están dando cosas para repensar y seguir trabajando. Y por supuesto, cuando nos inviten a que les platiquemos un poco, pues tenemos muchos expertos, entre ellos nuestro coordinador del día de hoy, Octavio Gómez Dantes, quien ha estado contrastando con muchos escritos junto con Julio Frenk cómo debían hacerse las cosas. Y de veras, muchísimas gracias a nombre del pueblo de México, a nombre del Congreso y del grupo parlamentario que represento, el Partido Acción Nacional. Muchísimas gracias otra vez, Kristen Wisborg y Michael Osterger. Muchísimas gracias. Hasta pronto.
Gracias.
Gracias. Gracias a todos.
Thank you very much.
Thank you so much.
Thank you so much, Kristen. Muchas gracias, Jorge. Gracias. Estimado Salvador Reading, muchas gracias. Espero haya disfrutado de la plática. Jorge Hermano, muchas gracias. Claudio Marte, muchas gracias. Jorge Jung, gracias. Almodelia. Se quedaron preguntas en el tintero, como el manejo de la tuberculosis, detección temprana de enfermedades infecciosas, planes y programas de preparación para las pandemias, pero pues el tiempo es breve y la ocasión perfecta en este momento.
Muchas gracias por la invitación, Héctor. Muy interesante.
Muchas gracias. Hasta pronto. Agradecemos al canal de Congreso, a nuestro servicio de traducción. Muchísimas gracias a todos los que nos apoyaron para hacer posible este evento.